Hi everybody, welcome back to the PTC podcast. I'm here with Dr. Samira Cutts, cognitive neuroscientist and occupational therapist. Is that right?
That's right. Well done.
From King's, thank you. We did a few rehearsals for that. So we've obviously known each other for quite a while. You've sent a lot of patients to me in the past. So I just wanted to have you on, have a little chat about all things neurocognitive therapy?
Yeah, well,
science.
Just anything neuroscience related is good.
Yeah, maybe speak a little bit louder into that as well again.
Okay.
Like I said, you've sent a lot of people to me, various clients, stroke patients, recovering from strokes, people who've been wheelchair bound in the past, and we've always had kind of interesting conversations deep in the nerdy end of the neurophys world. So we'll give it a go today and see what nerdy chat we can come up with.
Sounds good.
But you want to just talk about why you kind of ended up in this little domain of the medical world?
It's pretty niche. So it started off with me being an occupational therapist. Just from a really young age, I was really interested in the human body and how it worked. And so I decided I wanted to treat people. But I knew I didn't want to go down the route of drug interventions or surgery, and I wanted to do something more natural. So I spent some time in a local community hospital doing some work experience, and I fell in love with it, occupational therapy. It's very holistic, and it really incorporates a lot of the physical along with the psychological, social, emotional side of things. So I really liked the holistic manner of treatment. So qualified as an occupational therapist and worked in a variety of different clinical specialties like neuro rehab, surgery, trauma orthopedics, spent a lot of time in cardiorespiratory medicine, and then decided I wanted to specialize in neuro rehab. Practiced in England for 10 years and then came over to the UAE and then worked in an awesome brain and spinal cord injury unit for about 5 years. And it was during my time there where I felt like when you're qualified for about 10 years, you think you kind of know everything. And then you come across a few patients that humble you and make you realize that you really don't know everything. So I had a few really complex, challenging people that had spinal cord injuries. And we did some really beautiful work with them and got a lot of function back and really improved their quality of life. But the feedback was always the same. They would always say, you did nothing to address my pain. And my pain is heavily impacting on my happiness and my levels and my mood state. So as a clinician, I felt like we are not very well trained to manage chronic pain. So I decided to go on a little pain quest journey, so to speak, and I'm still on it today, 15 years on. So
what kind of thing would you be able to restore relative to people still being in pain for people with spinal cord injuries? Like what restorations can you do?
It depends very much on the spinal cord injury. It's very unique, so depending on the level of injury. So obviously with being an occupational therapist, and I'm also a specialist hand therapist, we would focus heavily on the upper limbs. I would tend to work with people with C5, C6 level spinal injuries. So we could get some really nice function, so in their elbows predominantly.
So at C5, C6,
it's around the elbow forearm region.
Low forearm. So they've got sensation around.
So they can move everything from the elbow downwards.
From the elbow down?
Yeah.
So they can go wrist and fingers?
Yeah.
They can't or they can?
They can.
They're able to?
Yeah.
Oh, okay. I would have thought it was the other way now.
Oh, sorry. No, it's the other way around.
Yeah, okay. Yeah, above.
So they can move everything from the elbow above.
Yeah.
Yeah. So that, functionally speaking, is very, very challenging. And also what we want to try and do is reduce as much deformity as possible, because if you don't use it, you lose it.
Yeah.
So rehab is really, really essential to maintain as much upper limb function as possible. Yeah.
We worked on a patient together who had a lot of kind of hand issues. I don't think it wasn't
he had inflammatory polyneuropathy.
But on the user or loser, his hands were quite curled.
Yes.
So by not using your hands, basically the fingers will curl and the thumb will become...
So you'll get what we call fixed deformities and contractures. So contractures are where there is a shortening of the tendon, but permanent. So once that damage is done, it cannot be undone, and you lose that function wherever the shortening of the tendon has occurred. So with people where they're not able to use their hands, or they have deformities in their hands, it's very, very important to stretch out the tendon length and the tissue so that they can at some point regain that function. But if that tissue length is not protected, they will have a deformity, and they will have a long-term disability in the sense that they won't be able to use their hands in a functional manner.
So going back then to what you were able to restore for the people who had the spinal cord injury, that's the kind of thing?
So that's the thing that I would do traditionally, except we didn't do anything for their pain. So I would regain function, but they would still be in really excessive pain, like a level 8 or 9 out of 10 pain, which is a lot. And when people are in long-term persistent pain, that impacts on their mood state, which means they're then very highly susceptible to getting clinical depression and anxiety. Typically, also socially, what happens is they avoid people. They're people that love them because they're constantly grouchy, snappy. They don't want to be like that, but they don't know how to manage it. And so they distance themselves from the people that they love, their family and their friends. And then they're socially isolated. And so chronically speaking, that creates a lot of loneliness. And then a year or two later, they notice that their life has massively changed. They have no friends, their family dislike them, they're in constant pain, they're not going out, they're not actually involved in anything that they want to do in their lives. And it's a pretty bleak landscape for them. So the pain element, I realize, is probably the most important thing, perhaps even more important than the function. And as a clinician, we aren't really doing anything to support them or to address those issues. I work heavily in chronic pain management now, and I get a lot of work because most of the clinicians don't enjoy that area of work. They find the people are difficult, or they're catastrophizing their experience, and they don't we don't really have we don't really as clinicians have a great toolkit to work with when managing long-term persistent pain. There are many things we can do with acute pain. There are many things we can do with musculoskeletal type pain. There's very little we can do with neuropathic central nervous system based pain.
So do you want to just explain a little bit the difference in those two? Like, what is, you fall down, you hurt your knee, it's sore for a bit, then it's not sore. You have a more severe injury, you have more severe pain for longer, but then there's this whole other realm of pain in the brain.
So let's speak a little bit about, you said acute versus chronic. So acute pain is any type of pain that you experience from a particular event. Sometimes there's no event, up to 3 months. And very simply, chronic pain is any type of pain experienced for a period from 3 months and beyond. And then once somebody switches over from acute to chronic pain, their pain circuitry has shifted. There are nervous system changes that have been created. We then like to divide pain into different mechanisms. So there's what we call nociceptive pain, which is the musculoskeletal type pain that you have in your muscles and your joints. And there is neuropathic pain. We don't really like to use that term because it's a very difficult type of pain to diagnose, but that's the more central nervous system based pain. And so when an individual experiences, say, pain in their knee, as a clinician, it's very important for us to ascertain what type of pain state they are experiencing, because the treatment methods for them vary wildly. So the type of drugs that we would give somebody for nociceptive pain would be NSAIDs, so non-steroidal inflammatory-based drugs, and they do nothing for neuropathic pain. So if we have a patient that comes into clinic and they're in chronic pain, so they've been in pain for 2 or 3 years, it's quite severe, and we just make the assumption that it's nociceptive and we give them NSAIDs, they're still going to be in pain, they're going to come back. Typically what happens is the surgeon will do some scans, there may be some degenerative changes, they might suggest surgical intervention. So we've already jumped the gun and gone down the surgery route without really understanding what pain state this person is experiencing. So what I'm trying to do with my work at the moment is to help clinicians to, first of all, diagnose the correct pain state, which is very complex because it's not a clear-cut case of, it's either nociceptive or neuropathic. It could actually be a mixed pain state as well. So even the nature of the pain itself is quite complicated, but the starting point needs to be the diagnosis. And then the secondary element to that is, what tools do we have to treat the neuropathic central nervous system based pain? And that's where currently Western medicine is stuck. There are very, very few options for that. And during my pain journey, having completed my master's in neuroscience, I came across some wonderful neurotechnology, neuromodulation technology called non-invasive brain stimulation. Non-invasive brain stimulation is an external device. It's a very conservative management of pain, where we can stimulate an individual's brain using electricity to essentially fire neurons to create changes on a network level to their brain, and it actually helps to manage pain in a really great way. So that's what I've come up with so far, and that's what I'm trying to advocate now for the future, certainly with my clients, to try and help people with long-term persistent neuropathic pain.
Okay, we'll talk about that, but one thing I just want to come to at the start of what you said, when we just so that people can kind of understand potentially where they are in their own pain journey. Anyone listening to this who's got back pain for years, it's back pain for years, that kind of thing. When you talk about the timeline, you've got your acute, then you got your chronic after a certain amount of time, and then after that, at some point in the future, it changes to neuropathic. But it can still be...
Not necessarily. It doesn't necessarily have to change to neuropathic. So there are different pain states. You can still have chronic nociceptive pain, or chronic neuropathic pain, or a combination of the two.
Yeah. Okay. That's kind of what I want, because it's not just one evolves into the other.
No.
They can coexist.
Yeah.
And that's where the complexity comes in. You don't really know which one it is.
And also, when it's a mixed, majority of the time, it's a mixed pain state. And so then you have to take several options where you do have to explore medication. I am an advocate of medication. As much as I don't like it, it does have its place, and it can be helpful when prescribed appropriately. So medication does have a place, but not enough clinicians are exploring the central nervous system based pain because they're not trained to, because this is all quite new. Non-invasive brain stimulation has been around since 1983, but most people don't know about it. So if you don't know something exists, you can't then prescribe it. So we need to, as a community, really educate each other and recognize different types of technology that's on the market now that can actually help people in a way that's actually a lot more successful at treating pain than drug interventions, and has a lot less side effects, so it's actually safer.
I like how you said that 1983 is not that long ago. That's
it's not for me.
That's
I'm still young.
Yeah, that's older than me anyway, so that makes you feel a little bit younger. But that's a long time. That's not that recent. Like, that's 40 years of
I think what happened really was, in the medical community, drug interventions became really, really popular, and the big pharma companies kind of took over the whole game.
Yeah.
And so all of the other type of research that was doing well just got covered. People became disinterested in them and became really... It's very easy to market drug interventions. It's very financially profitable. So the focus was always on drugs. But I think we're now moving into an era, certainly in this region, where people are less keen on drug interventions. And if there are more natural, holistic methods, people would prefer those options. And I think people are a lot more open-minded also in exploring Eastern medicine techniques. There used to be quite a big taboo around Eastern medicine techniques, and people used to make comparisons with Eastern medicine with Western medicine because of the lack of evidence base. But the two operate on a completely different frame of reference. You really can't. It's like comparing apples and oranges. And that's not to say one is better than the other. They are just very different approaches. And with that in mind, I think now with the neurotechnology that's coming up, people are a lot more interested. And there's some really nice research that's being completed that actually identifies very quantitatively that non-invasive brain stimulation can treat a wide variety of neuropsychiatric conditions much better than drug interventions and much less side effects. So who wouldn't want a treatment that is much safer and much more clinically effective, and the remission rate is higher, which means that the long-term changes and the changes are long-lasting. So, for example, one thing that non-invasive brain stimulation is great at treating is depression. It's actually better at treating depression than drug interventions. And the research has shown that those individuals that are drug-resistant to depression, so they're on drug interventions and they've not had any improvement, do really well with non-invasive brain stimulation. And the improvements last for much longer than the drug-based interventions in the first place. They could last for about 2 years. And then you could have maybe a quick induction phase of another dose of non-invasive brain stimulation, and you're good to go for another 2 years. And there's very, very, very minimal side effects.
So how does it work, this non-invasive brain stimulation? What
so
is it? And because you've told me about it, so I've got an idea. What I'm imagining is it's some sort of hat that's shooting gamma rays or radio waves into my brain. No. My brain is going ping, 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 and then I'm not in pain anymore.
No.
Okay.
I wish. That
If
sounds
only.
wonderful. Maybe we should invent that. Not quite as sophisticated as your invention. The way that it works is you come in for a consultation. I will take measurements of somebody's brain. First, we need to decide what type of stimulation protocol we want to go for. So the stimulation protocol will determine what region of the brain I want to stimulate. So, for example, if I want to stimulate the motor cortex of the brain, that's kind of about here.
Which is kind of in the middle.
The middle towards the front.
Okay, yeah.
On the right-hand side. And so I'll take measurements to make sure I know exactly where my landmarks are. And then I'll have a big device next to me, and connected to the device is a long coil. And at the end of the long coil, there's sort of like this butterfly type device, and
like
I will place it on the person's head, and then I'll crank up the electricity, and I'll put in all the numbers. I have to determine how much electricity, so what the frequency is, how many pulses, how many trains within the pulses, and all of that. So put it all in, and then off it goes for either, depending on what stimulation protocol, it could either be for 2 minutes or it could be for 20 minutes. And somebody would come in typically for a session 5 days a week for between 10 to 20 minutes, and you'd have 30 sessions, and then you're done.
So what kind of electricity is it? Because it's obviously not like
electrical impulses, so just normal electrical impulses. And
can you feel it if you're?
Yep. So we would do like a little test to make sure we're on the right part of the brain. So we do a little test with your hand first. So I'll zap a bit of your brain, and your finger will twitch and create a twitch response.
Oh, really?
So when you're actually doing the brain stimulation, it's not painful. It just feels, for me, I've obviously had my brain stimulated many times. It feels like a tiny little woodpecker just tapping on your brain. So it's not painful. There are a few side effects, but they're very, very, very minimal. But I go through all of the information.
What kind of side effects? Like?
So you could maybe have mild headaches or a little bit of dizziness, sleepy, a bit drowsy, just very generic types. And it doesn't last for very long at all. So, yeah.
So when you say what do you call it, the mid-cortex?
The motor cortex.
The motor cortex. Mm-hmm. So what would that help me with? Like from my pain perspective.
So I would use the motor cortex heavily in the treatment of neuropathic pain. So if somebody came to me, for example, my research at the moment is focusing on knee osteoarthritis. So we're looking at people that have chronic, very severe knee osteoarthritis. Let's say they've had it for a few years. They've tried a few different drug interventions. They haven't been successful. Perhaps they need to have surgery if they don't want to go down the surgical route just yet, because there are a subset of patients, between 20 to 40% of individuals with knee osteoarthritis who will not benefit from knee surgery. So it is such a shame to go through.
Because their knees are so badly damaged?
Because surgical intervention can't treat central nervous system-based pain. So if the clinician has not identified what pain state they have, and they've tried drugs and they're not working, he or she may be going on the assumption that it's so severe, the structural damage, that they need surgery. So they'll take them through the surgery.
So what would that be? Just a knee replacement?
A knee replacement. Yeah. And then once they've recovered from the knee surgery, 20 to 40% of people will say the pain is still there, or it's actually even worse now. And that's because that pain that they have is central nervous system based. And no surgery or drug intervention with the NSAIDs will manage that. And the few neuropathic pain drug options that are on the market are not very successful, and they're highly addictive. So we don't like to give them.
What are they?
Opioid medication. Yeah. So we don't like those, and that's not a long-term option. And those can be exhausted, and then where do you go from there? So it's a pretty dire situation. So that's why I'm so excited about non-invasive brain stimulation, and especially because the research around it, the statistics are just fantastic. And I want everyone to know about it, and I want people to be able to go to their physician and say, I heard about non-invasive brain stimulation. Can we try it? Let's see how it goes. It's another option, another tool in our toolbox that we can offer, and it looks really, really promising. So I'm really excited.
I mean, look, as soon as you start going up against the opioids, if the opioids is an option for some people, then you're taking on a big beast, a big monster. So that maybe gives a bit of more clarity as to why this has been around since 1983 and not being...
Absolutely. People don't really want to market an intervention that isn't drug related, and they can't make huge amounts of money from.
And actually can fix the problem and have the person stop coming back for more.
Exactly. And actually the research for depression and OCD and addictions shows that it can actually cure them. And we have really special protocols. So there's this amazing protocol that's been developed by Stanford University in the States, and they call it the Stanford Protocol. And they use a protocol called theta burst stimulation. That's where it's really, really fast, and it comes in 3 trains, super, super, super fast. So it's a repetitive form of brain stimulation. The treatment takes 2 to 3 minutes, but you have about 5 to 10 sessions a day for 2 weeks. And after 2 weeks, you do not have depression.
Really?
It's phenomenal. It's not for everybody, but I think the statistics show it works for about anywhere between 40 to 60%.
That's actually quite high.
That's
also
much higher than drug interventions.
You need to then look at, for the other 40%, like what else are they lacking in their social environment?
Exactly. So what's really nice about non-invasive brain stimulation is it can be used as an adjunctive treatment to talking therapies and to physical therapies. So it's not to negate any of the other things that are out there, but it's advocating more non-invasive conservative methods of management.
You probably wouldn't get 100% success rate even if you had the most perfect tool, because there's so much complexity involved with something like depression.
Absolutely.
But if you can take those 40% who don't benefit from it, turn down one of the volumes of the feeders into the depression mechanism, and then get them into more social, more communal, more like fitter, exercise, diet, all that stuff.
Absolutely. So I want to talk a little bit about how non-invasive brain stimulation actually helps people. So I'm going to get into the science part of it a little bit.
Yeah, do it.
So essentially, I want to just mention transcranial magnetic stimulation. So that is the specific type of brain stimulation that I'm working with at the moment. So that's the big one, the bad boy. So we call it TMS for short. So essentially what TMS does is it helps us to fire more neurons in our brain. So when I stimulate a region of the brain, what I'm doing is I'm increasing the amount of action potentials our neurons can create, which then leads to what we call motor evoked potentials, which then leads to more firing of neurons. When we have more firing of neurons, what we're doing is we're increasing synaptic plasticity. So the brain is very moldable. It's we call it bioplastic because it can change very well, and it's very easily influenced by the environment and from the sensory stimuli that we take in. So this is what we're doing. So we're influencing the brain by increasing the amount of synaptic activity, and essentially we are creating long-term lasting changes by changing and helping the brain to learn. So it's a concept that we call neuroplasticity, and we use it heavily in rehab. So at the moment, we do a lot of intensive, hard labor, usually through movement, to create this concept of neuroplasticity, to create long-term positive changes in the brain's network. The non-invasive brain stimulation does exactly the same as that, but much faster than we can as humans.
Okay, let me see if I can translate what you just said,
Okay.
and you can tell me if I'm right or wrong. So the what did you call it?
Transcranial magnetic stimulation.
Magnetic
TMS.
stimulation. When you talk about it, stimulates more of the action potentials of the neurons. So what that means is basically the sleepy nerve cells that are there.
Not even the sleepiness, it's just the same ones, but it just makes it happen more. There's a higher volume.
So we're talking about really bad internet connection.
Yeah.
You improve the cable network, you get a better signal, which means that on your TV screen you get a nice smooth image playing all the way through.
Yeah.
Without that stimulation, you've got poor conductive cabling that delivers a less clear image on the TV screen.
Kind of.
So by putting this transcranial magnetic stimulation thing, you're turning that cable firstly into a better conducting cable to give a better output at the other end.
Yes.
And then that's what you're referring to when you say the synaptic activation.
Plasticity.
Okay.
Yeah.
So then with the plasticity, that's basically referring to, as we learn things, our brain lays down new tissue, we'll call it for the simplest of terms, that's in line with that new skill or that new language or that new thing that we need to store.
Absolutely.
So the plasticity is like plasticine. It's like turning a block of plasticine into a little farm animal, or turn it into a shape.
Absolutely.
And you can alter that, and that's something that they thought the brain couldn't do after the age of 25 originally in the old science days.
Long time back, yeah.
But now they know that you can, to some degree, improve that neuroplasticity.
We do. We know the concept of adult hippocampal neurogenesis now, which is the formation of new brain cells as adults. Before, we thought that as adults we are not capable of that, but now we know we are, which means that even in our old age, we are still capable of learning and developing.
Okay, so then you said that, and I interrupted you when you said that the work that you're doing can do exactly the same as that transcranial magnetic stimulation.
That's correct, yeah. So what's nice about it is you can combine the TMS brain stimulation with regular rehab or talking therapies, and then you're getting double the amount of neuroplasticity, which means everything just happens much, 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 much faster, and it consolidates that learning much better.
So taking that then, what we're talking about so far has been movement and motor cortex and kind of physical brain body realm, the realm of stuff. What about like neurodegenerative conditions?
So that's a whole different ball game. At the moment, there's not that much research. There is research that's coming out, but it's still elementary in showing any signs of helping people with neurodegenerative conditions like dementia. But Parkinson's, which is a neurodegenerative condition, can be supported with the use of brain stimulation. So there are different types of Parkinson's disease, and people with Parkinson's have both motor and non-motor symptoms. So the people with motor symptoms are individuals that have the tremors and have very physical symptoms of degeneration, predominantly from the gross motor skills. And then the non-motor side of things can be cognitive decline, depression, anxiety, amongst lots of other things. So the non-invasive brain stimulation can't help the tremors, but it can help the depression and the anxiety and try to have an impact on some of the cognitive aspects. It can't stop the decline, but it can safeguard what you have to a certain extent, we think. So again, the research is very early. Also, you have to question the research that we have. So sometimes a paper can look really exciting and great, but when you go through the critical analysis, there are many flaws. So if you can't replicate the same results, it's actually not so exciting. So there's a little bit of that going on in Parkinson's research at the moment. But
a little bit of what? A little bit of like unclarity as to what's actually happening with the studies that are being published?
With the non-invasive brain stimulation. So some clinicians are open to it, other clinicians don't like to use it with their patients. So again, I think there's a lot of education that's required. And you can't just say, oh, brain stimulation doesn't work with Parkinson's patients. That's not accurate. What you need to say is it's not helpful with the motor symptoms, but it can be helpful with the non-motor symptoms, more related to the cognition and the mood states.
And is this relative to the severity of the Parkinson's, in the sense that if you catch it early enough, is there a way, because you mentioned you can hold on to what you have, or you can slow the decline? Is that possible?
So as with all neurodegenerative conditions, if we catch it early, we can try to slow down the prognosis and manage the pathophysiology a little bit better, so everything happens a lot slower. Because we know with neurodegenerative conditions that does lead to a lot of decline in your motor physical abilities, your cognitive abilities, your the sensory abilities, and overall can lead to a huge loss of function and then dependency. So what we're trying to do is slow down that process so that it takes much longer, so that you can maintain and hold on to your function for longer and increase or maintain a higher quality of life for longer.
And this might be not a useful question. Is that relative to how fit and healthy the population are? I mean, is this, because what I am assuming, the people that you're seeing are the people who are kind of already off the edge of the cliff, and they're already in this state of diagnosis, because however long it takes for the disease to be present before the diagnosis happens, they're already at a certain stage where it's pretty much, it's too late now, there's not much we can do to reverse it. But had you gone back 15, 20 years and you look at people's diet, their exercise, their mindset, their philosophy.
This is very specific to dementia patients, so people that have Alzheimer's or another type of dementia like Lewy body dementia. So dementia research has been really, really insightful in the last sort of 5 to 10 years, and we've learned many, many things that we didn't know before. And that has now guided us to focus our therapies on really focusing on lifestyle factors to manage those. So I want to talk a little bit about just the science behind dementia, if that's okay. So what we now know through the research is that the hypotheses, shall we say, we never really know for sure, but a strong hypothesis that most people think is quite accurate is the beta amyloid hypothesis. So this suggests that what happens in our brains is we have a high volume of a protein called beta amyloid, which is also a neurotoxin that accumulates in our brain over time. When I say over time, I'm talking 15 to 20 years. So that's why we say with dementia, it actually starts to brew and happen 15 to 20 years before the point of diagnosis. Unfortunately, Western medicine is not sophisticated enough at the moment to have very, very clear biomarkers during that 15 to 20 year period where you could have a checkup, identify you've got an accumulation of beta amyloid, and then do something about it. We're just not there yet. So unfortunately, we don't find out until they already have a really high volume and the damage is essentially already done. And then we can diagnose it. We don't have any preventative measures. There's a lot of great research that's coming out, really focusing on biomarker development, but there's nothing concrete just yet. And so we know that we have a high volume of neurotoxins that create a high volume of beta amyloid. And then we also, alongside that, have another thing called tau proteins, which again is a neurotoxin. I keep bumping my face there. Sure. And there's this interaction between these toxic proteins, and it creates what we call neurofibrillary tangles. So this is all happening in the brain, literally clotting the brain with neurotoxins. And then that creates a death to your neural tissue which cannot be undone and cannot regenerate no matter what. And that's essentially what dementia is. And we don't find out about this until it's already happened 20 years down the line. But also what the research is now showing is that there are many factors such as sleep, alcohol and stress, which are like the top 3 killers of dementia. So historically, people really thought that dementia was a genetic issue, that there was just something genetically inside of one that where they are predisposed to that condition. But actually now the research is contrary to that, and it's showing that it's more the lifestyle element alongside the genetics, but less of the genetics. And we also know about epigenetics now, which is where somebody has, a set of genes which may determine if they have particular conditions, but those genes, the gene expression, is heavily influenced by the environment. So you could be in a toxic environment that could switch these genes on, which means you then get a particular condition early on. Or you could be in a really healthy environment, which means that those genes are not switched on and you never get the condition. So that is also an important aspect. So there are many things from a lifestyle perspective that one can do to prevent a dementia diagnosis, but the work has to be done 15 to 20 years before. So kind of when you're 30s and 40s, really. I
mean, because I got dementia, Alzheimer's in my, I don't know what you call it, not my parents and uncles and aunts, but in the generation before them.
Right.
Obviously they're much older, so they reached it sooner. But so I've done a little bit of reading and research, and when smart people talk about this topic, I particularly listen, because it's one of those things where you wonder, is it going to be down the pipeline? And firstly, you can tell me if it's not correct or what, because I'm really only just parroting what I've heard other places, that the hereditary Alzheimer's and dementia is actually quite a low percentage, the early onset dementia. It's not what you think, just because your grandparents and whoever else had it, that your dad's going to get it, your mom's going to get it, then you're going to get it. And then there's a bunch of the non-modifiable risk factors or predetermined, like your gender, your age. Obviously you can't change them, and like you said, your genetics you can't change, but you can change the expression.
That's right.
Of the genes based on what you're doing in your day-to-day life now. And they're starting to think that it's relative to kind of like a glucose metabolism, like it's almost, I know we spoke briefly about the book from the early 2000s, whatever it was, the Grain Brain, but aside from that, they're kind of thinking that it's a lot to do with insulin resistance.
That's right.
So aside from your type 1 diabetics, which is the pancreas problems, the actual cells not being able to uptake the insulin that your body can produce is creating this insulin blockage, which then effectively causes a cascading list of problems, which is more your domain than mine.
What's really interesting here is, I think what you've actually mentioned without mentioning it, is the gut-brain axis. So obviously I'm a brain person, I'm not a gut person, but I know about the gut because of the brain. So we now know that there is a direct connection between the gut and the brain, and actually many people consider the gut as the second brain. There's actually even one clinician that said actually it's the first brain and the brain is the second brain. That's how important both of those organs are. And that's how closely they work with one another. So now what's so interesting in basic science and in medicine is this evolution and understanding of a system-based approach and how everything works together. So there's an area of study called psychoneuroimmunoendocrinology, bit of a mouthful, and what that does is it's a study of both the psychological processes, the immunological processes, so our immune system, and our brain and nervous system, our brain and spinal cord, combined with our endocrinological system, which is the hormones. So people are clinicians and scientists are realizing that all of these main systems are working together in the development of a chronic disease and illness. So when we are trying to manage or eradicate and cure these conditions, you can't just come at it from a brain perspective or from a gut perspective or from an immune system perspective.
Or from a medicine perspective.
Yeah, you have to come at it from every perspective. And traditionally, medicine has always been very pathology based. It's a very reductionist approach. It's let's identify where the pathology is in the body, either cut it out or shrink it, remove it with drugs, and we're good. And now we understand that it's not that simple. And it has a knock-on effect, a domino effect on every system in your body in the areas that I mentioned. And actually, to really tackle the chronic illnesses, you've got to look at it from a holistic perspective. And so the gut-brain axis is really, really, really interesting, because as a clinician, as a treating clinician, and in terms of my research as well, I'm not a basic scientist that works in a wet lab. I'm actually a translational research scientist that works in a clinic. So what that means is I'm not looking at a cellular level of a person. I'm looking at the end part of a person where they've already got that disease. And I'm looking at treatment mechanisms or methods that will help to treat the disease right now. I don't want to look at the place that we start on a cellular level that can prevent it for people in the future. I need to work with people right here, right now. What can we do to help them? And so what's really, really interesting is that a lot of great people like Max Lugover that we mentioned, that we spoke about earlier, and a lot of really great dietitians and fitness and health professionals all around the world are understanding that we can really tackle a lot of these chronic illnesses through diet. So the carnivore diet is really, really interesting and has picked up a lot of popularity, also a lot of enemies, but I actually think it has a really good place. And they've actually found it to be really, really effective in treating a lot of symptoms of autoimmunity. And the reason why it's been successful is predominantly because it tackles the insulin issue. And so they're onto something there. So as much as there are enemies and people that don't like it and think that it's dangerous to eliminate so many things in their diet, it's a really great starting place for people that are starting to show symptoms of autoimmune issues, because that's where the large majority of chronic illnesses take place. You're going to start by showing signs of brain fog, rashes, multiple joint pains.
Unexplained joint pains.
Neuropathic pain, unexplained things.
Also massive
high level of stress. And not being able to manage that stress. So these are autoimmune issues. And so people need to take this really, really seriously, because that's their body and their brain talking to them, saying, hey, I'm really not happy. If you don't do something about this, something really wrong is going to happen in the future. And that's the point where people need to sit up, really take it seriously, and really aggressively eradicate these symptoms through movement, through diet, nutrition, and psychologically by managing their stress and maintaining a good mood state. And by doing so, you can actually prevent all of these chronic illnesses from actually taking place in the first place.
I think it's also worth noting as well, there was research done in the early 2000s that kind of connected the cause of, you mentioned the amyloid and the tau to aging. And this guy made this study in 2006 and said, look, we got this medicine and it can cure Alzheimer's, or it can reduce it. And recently that paper has been retracted, that the guy completely made up, he photoshopped his brain scans. So interestingly, so it's based around the beta amyloid hypothesis. So one of the key papers that actually brought the beta amyloid hypotheses into popularity was this one key paper by this one neuroscientist, but they actually identified that it was fraudulent. But actually, he photoshopped his scans.
Terrible.
Like, it's not just that they sort of squirmed the data. Somebody else went through those images in 2006 and saw that he doctored the scans.
It's incredible what some scientists will do. It's terrible and it's unethical. But it gives so many people the idea that now Alzheimer's is curable. So we just wait to get it and then we cure it. And now they've realized that's completely wrong. And so there's like 15, 16, 20 years of patients who've been taking this medicine who've just let it deteriorate by not modifying the other risk factors and getting into the prevention mindset. Even now, though, I think that everything is based heavily on medicine, and still people are not advocating the importance and value enough of movement. For example, strength training is really great.
Well, this is something I wanted to talk to you about, just exactly to agree with you. And we won't say more than 2 words. COVID-19, health or vaccines. Like, there should have been 4 conversations. There should have been, this is the vaccine to help people get better, prevent it. This is what we do when people get sick. We go to the hospital, we give you this medicine and this medicine, this medicine. This is how you don't do it. And then this is just the supplements and the vitamins that you can take to give you the best chance. It's not going to cure it, but instead of just getting COVID, closing the door and waiting to see if you live or die, you can take vitamins, zinc, you can take this, that. Like, those 4 conversations should have been happening. But people were not interested in the second 2. They just wanted the vaccine, which is so weird that they weren't just looking for the medicine, because there wasn't enough money to be made off the medicine. But that's just exactly what I said. But I'm not going to go down that route. We'll be here forever. But that you mentioned strength training, and this is something that I wanted to ask you about as well, because from seeing knowing your training history, you like to lift heavy. Yeah. And you're not a particularly you tell me why do you like to lift heavy, specifically heavy, not just you like gym. In the gym world, you still lift heavy.
Various reasons. Obviously, being a neuroscientist, I know the importance of strength training for my brain. So I purely strength train because I know how great it is for my brain. It's incredible. It's almost like a cognitive antigen.
But to be specific, sorry to interrupt you, I want anybody listening to this, it's not strength training like let's go to the gym and lift the dumbbells and lift the
heavy.
You go like as heavy as you can.
To maximal, at least like 2 or 3 times a week. So
you particularly put in as much weight on the bar that you can lift only once or twice, maybe 3 times.
As much weight on the bar as my coach allows me to. But
but strength training in this day and age, great, has just the idea that you don't like to do step aerobics or aqua aerobics or Zumba. You like to go in the gym and lift weights. But you like to go really heavy.
Because it only works if it's really heavy.
Okay, so...
so
tell me why.
The research shows
for the brain.
The research shows that strength training can act as an inoculator. It's a protective mechanism for cognitive decline, but it only works if you lift to submaximal to maximal levels 2 to 3 times a week. So it's not enough that you just go in and wait and lift some regular weights. It has to be heavy, otherwise it won't work. And actually there are many, many other benefits for lifting really heavy. I'm a lady over 40, so I need to look after my bone density. It's very empowering, so mentally it's great, because I think if it feels good and it makes you feel stronger mentally, that makes you physically stronger. It's almost a form of therapy as well. It's like a magical pill. Lifting heavy is like a magical pill. It protects you against so many things, physically, mentally, and also you make great friends as well. So, what's not to love about it?
I don't dispute any of that, but what I really want to drill in on is what effect does the heaviness have on the brain? Because the stuff you just said is true, but also with a bit of an aerobics class and a spin class also helps you. Great for the brain and great for your mood and great for your community. Hiking is great.
We actually don't know. We don't know.
Really?
But there were studies that have looked at different level of weights, and they identified that it was the heavy lifting that was more of an inoculation towards cognitive decline. But why? We don't know. And again, clearly it's working on a network level in your brain. But often we don't know the reason why. For example, with brain stimulation, we know that it works. We don't understand fully why it works. The way brain stimulation works is we will either target a brain region or a network, and we will stimulate that. Or sometimes, like for example, with stroke patients that have damaged, say, a part of the dorsal lateral prefrontal cortex here on the right side. Let's say that's damaged. Instead of stimulating that, we'll actually stimulate the good side of the brain on the left side. So the same part of the brain, the dorsal lateral prefrontal cortex, and we'll stimulate the good part, because then we're helping the good part of the brain to become extra good to overcome the loss of function on the right side. And we know that works, but we don't know why it works. We just know it works. So there is a lot that we still don't understand from the research that is being conducted, but that's the beauty of translational research, and that's where the basic scientists come into play. because they're the guys that want to know why it works. They're not happy with the fact that it just works. They want to know why it works. So you do have to sort of take a bottoms up approach and then sort of work your way back to the beginning to find out on a cellular level what's going on, what changes on a cellular level are being created that makes heavy lifting so good for your brain. We're not there yet, but there's a lot of work involved. We keep going.
So we'll almost wrap up because I want to be respectful of your time, but we've talked about I'm talking in the realm of exercising for your brain, lifestyle for your brain, things to improve your brain health. We've got lifting heavy in the exercise. As you said, you're not a food person, but what other lifestyle things do you do from your experience that help you, or from your reading and whatever your worldly professional experience? Like, what else can people take home, and what other little tips can people do? Sleep, that kind of thing.
Sleep
Alcohol.
is extremely important, specifically slow wave sleep. So it's not enough that you just sleep, say, between 6 to 8 hours. The quality of the deep REM sleep, the third stage of the sleep, there are 4 stages of sleep. So we want the third stage of the sleep, the SWS, slow wave sleep, to be really high quality. So it's worth measuring that, which you can do quite nicely with some technology now these days. So making sure you get good quality sleep there, because that's when we are actually able to clear out the neurotoxins in our brain, and that's when the synaptic activity takes place. So the whole point of sleep is to create learning and development, and it does that by getting rid of all the things we don't need and consolidating the synaptic activities that we do need. And that happens in the SWS sleep. So that's related also to the glymphatic system, where I did a bit of research there looking at the clearance of the brain and when that happens and what time. So it's specifically, we know it specifically happens typically.
So what's glymphatic drainage?
So glymphatic drainage is drainage of toxins within the brain. So we all know about the lymphatic system, which is the brain's system that clears out all the toxins from our body. So we have a very similar system, but it's specifically just for the brain, and it clears out neurotoxins like beta amyloid and tau that we don't want, and it helps us to create learning and development from the things that we've learned during that day. It specifically happens in slow wave sleep during 2 to 3 a.m. So circadian rhythms are really, really important. Understanding your own personal circadian rhythm and having consistency with that is important. And being able to support your body to sleep the right amount and get the right amount of slow wave sleep is really, really important as well. So sleep, that's one thing. Supplementation, I think I'm a big fan of. So I think, taking basic things like vitamin B12, B6, omega is really, really, really helpful. Magnesium, creatine, all really great neurotropics for your brain. Reducing or eliminating alcohol is really, really helpful. So more and more research that comes out present day is showing that actually no alcohol is better, even compared to a small amount, because there was a little bit in the cardiac research saying a small amount of red wine is actually really good for you, but actually from a brain health perspective it's really not. So that's a tricky one, but the takeaway is to minimize it as much as possible. Nutrition, keep it simple. So I think with nutrition, people really need to, there are so many different dietary theories out there. And the reason why is because there's not one cookie cutter approach. We are all so unique in our makeup, and you have to identify for yourself what works for you and what doesn't. What's inflammatory for one person may not be inflammatory for another. So pay attention to what you're eating and how it makes you feel. If it doesn't agree with you, get rid of it. It's so important to make that connection. So that can take a little bit of time, but you've got to put the work in to yourself if you want to see the health benefits. I think often people rely on professionals to guide them, but actually who's the person that's best placed to get to know themselves is that individual. Yeah. So do the work and be a project manager for your own health to really help that happen. And of course the big one for me is movement. Like, everybody should be moving every single day. and there should be a heavy amount of focus on strength training with cardio. But again, even on the cardio side, it doesn't always have to be high intensity, especially as you get older, because that also aggravates and annoys your endocrinology system and your immune system. Like certainly for me, like doing a lot of high intensity work, it wreaks havoc with my hormones. I know it's not good for me, and there's an increase in cortisol production. So doing more low intensity cardio for me actually works a lot better. So yeah.
Okay, amazing. Look, we'll wrap up now and let you go. There's loads there. I hope people can rewind and listen. But if people want to get in touch with you, you're on the King's...
I'm on the King's website, and they can find me on LinkedIn under my profile name, Samira Cutts, or on X. That's my research account. So again, Samira Cutts. Yeah.
Samira Cutts. All right, amazing. Thank you, Dr. Samira.
Thank you.
We'll do it again sometime soon. You can let us know how the research is going.
Thank you. Appreciate it.
Cheers, guys.